Hello, welcome to Understanding the Aversive and Physical Domains. In this lesson, we're going to explore two of the 6 domains of pediatric behavior management, namely the aversive and physical domains. Some of the techniques in these domains are considered advanced and performed more often by specialists. The aversive domain, which involves using unpleasant stimulus to shape behavior, consists of 3 techniques: parental exclusion, voice control, and hand over mouth. These techniques may be unacceptable to some parents and should be communicated clearly. Oftentimes, an anxious parent can unwittingly pass on their fears to a child patient. Having such parents in the treatment room can be counterproductive. An overbearing parent given competing instructions can also undermine the healthcare worker's authority. In these cases, parental exclusion can be used to improve cooperation. However, some parents may not be on board with this technique, and despite threatening to do so repeatedly, ultimately refuse to leave the room. The use of voice control is the change in intonation during treatment. This is usually carried out to regain control of the situation when the child is no longer listening to instructions. This does not always mean raising your voice. In fact, lowering your tone and volume may catch the attention of the child more than raising it. Like for example, "Stop it, I'm in charge here." Sometimes I like to go close to a child and change my voice almost to a whisper in their ears when they are losing control. However, this technique does not work on a hysterical child and may even backfire on occasions. Before you carry out the voice control technique, explaining your intent to parents, make them more receptive, as they will not perceive that you are yelling at their child. The hand-over-mouth technique is used to regain a control of a situation whereby the child is screaming and not listening to instructions. This involves the covering of the mouth of a child and speaking calmly to him. This is not used as a punishment, but to establish communication with a child that had lost control of his emotions. However, this technique has fallen out of fashion with most practitioners, and most parents have found it unacceptable. Another domain used in behavior management is the physical domain, consisting of active and passive restraint. Active restraint is the physical restraint of the patient by the parent or an assistant. Sometimes this may be the only way to conduct an examination in a pre-cooperative patient. In other words, a child less than 2 years old who is still in the sensory motor stage of development. This can be done via a knee-to-knee approach shown in the picture of an oral examination. As you can see, the patient's head lies in the lap of the dentist while a parent holds on to his hands. Other times, active restraint may be acceptable when it's used in a once-off emergent situation, such as the management of a trauma or severe infection in a pre-cooperative or uncooperative patient. It is important to note that regardless of which technique you choose to adopt, the risks and benefits of such techniques as pharmacological behavior management should be discussed with the parents before you decide together with the parent on the most appropriate technique to use. The use of passive restraint involves the use of various restraining devices. Devices such as the papoose board and the PD-wrap are designed specifically for the restraint of a child for especially painful procedures such as drawing of blood and tooth extractions. They are very effective but require good consent taking, and they are used carefully recorded. Sometimes improvised devices can be used for passive restraint. A blanket can be used to wrap up a child, and a pillowcase can be used to restrain a child's arm by utilizing his own weight. Specific devices such as a mouth prop can be used to keep a child's mouth open for treatment. Although when used correctly, passive restraint techniques may be safer than active restraint techniques, parents may still be less receptive to the use of such devices. To recap, the use of aversive and physical domains is helpful in managing pediatric patients. However, some of the techniques may not be acceptable to parents. Always get the parents on board by explaining the techniques you plan to use. Hello, welcome to Understanding the Pharmacological Domain and the Anesthesia Continuum. In this lesson, we're going to explore the final domain of pediatric behavior management, namely the pharmacological domain. The techniques in this domain are usually considered advanced and are performed more often by specialists. Additionally, we will be looking at the risks of sedation in pediatric patients. The pharmacological domain consists of minimal sedation, also known as anxiolysis, moderate sedation, also known as conscious sedation, deep sedation, and general anesthesia. Oftentimes, these techniques are employed for children who are either pre-cooperative, meaning that they are at a developmental stage that does not respond to other techniques, anxious, meaning they are cooperative but fearful of certain procedures, or uncooperative, meaning that they either are unresponsive to other management techniques or are undergoing invasive procedures. Sometimes, these patients may also have medical conditions that results in reduced ability to cooperate. Here are some common drugs that can be used for each different technique. For anxiolysis, a common drug used is midazolam, a shock-acting benzodiazepine. For conscious sedation, most practitioners will choose midazolam. And for deep sedation, surprise, surprise, is midazolam as well. What this illustrates is that it's not the drug choice, but the dosage and response of patient that determines the level of sedation. This is the anesthesia continuum, which shows the depth of sedation. A patient can move easily from one stage to another depending on how the body reacts to the sedation agent. This means that even if we were aiming to provide anxiolysis, the patient can slip into moderate or even deep sedation. It is important as the protective reflexes of a patient decreases as they become more sedated, compromising the airway and cardiovascular functions. As such, it is important to continuously monitor the patient during the procedure. And as a general rule of thumb, you should have plans to resuscitate a patient at a deeper level than the level you plan to work at. Generally, mild and moderate sedation done in office for pediatric patients is usually carried out on patients with ASA status 1 and 2. Patients who are medically compromised, such as poorly controlled seizures, type 1 diabetes, are poor candidates due to fasting requirements. Most of the high-risk factors are related to airway issues. This is because of the decreased protective reflexes and lowered patency of airways due to the sedative agents. As such, patients with abnormal airways, sleep apnea, obesity, and severe asthma are not good in-office sedation candidates. Patients at additional risk for aspiration, such as CP patients, are also not suitable for dental treatment under sedation, as the risk of aspiration is high from the dental procedure and decreased reflexes. Deep sedation and general anesthesia are more likely to be conducted in a hospital or ambulatory surgical center under the supervision of an anesthesiologist, due to the increased need for monitoring and protection of the airway. Additionally, advanced training such as PALS is required for the rescue of patients in such a stage of sedation. In addition, do a thorough medical history taking to rule out potential high-risk conditions. A clinical examination of the airway should also be conducted for sedation candidates. Children have small airways, which combined with the relatively large tonsils, means that they can have difficulty keeping airway patent under sedation. The Brodsky scale examines the tonsil size as illustrated. Brodsky 3 and 4 are poor candidates for sedation as the large tonsils reduces the size of airway, making it difficult to keep open under sedation. The Mellon-Patty scale looks at the extension of the soft palate. A Mellon-Patty 4 is a poor candidate for sedation due to the airway size, similar to the Brodsky scale. To recap, the pharmacological domain is usually used in situations whereby the other domains have failed or are not suitable. The different techniques of the pharmacological domain exist in a continuum, and a patient can move from one stage to another. Careful evaluation of the patient is needed to determine if they are suitable candidates for sedation.